Right. Well, hello everyone, and thank you so much for joining us. The Southeast Mental Health Technology Transfer Center would like to welcome everyone to the third session in a six-part series, Keeping It Practical, Core Skills from Evidence-Based Practices. This is session 3, Tools for Housing and Basic Needs, Lessons from ACT and Supportive Housing. Please join us every other Thursday for the other sessions in this series. My name is Emily Moore, and joining me in moderating today's event is Dr. Michelle Salyers, Professor of Psychology at Indiana University, Purdue University, Indianapolis, and Director of the ACT Center of Indiana. Before we get started, please note that the work of our center is supported by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. Please also note that our center and the larger MHTTC network use affirming, respectful, and recovery-oriented language in all activities. The Southeast Mental Health Technology Transfer Center is proud to serve the 8 states in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens through which we can address mental health priorities. We encourage you to visit our website, mhttcnetwork.org/southeast, to learn more about our center and upcoming events. A few important notes before today's event. This event is being recorded and will be made available on our website for on-demand viewing soon. We encourage you to share your comments throughout the presentation using the chat feature. Please remember to select Chat with all attendees if you would like to share your thoughts with everyone. We have allotted time at the end of our presentation to answer questions. Please submit your question using the Q&A feature at the bottom of your screen. Finally, for participants who are interested, a certificate of attendance is available for download after the completion of our evaluation surveys. I will now turn it over to Dr. Michelle Salyers so that she can present today's presenter.
Thank you, Emily. And welcome everyone, and welcome back. I hope a lot of you have been with us for our evidence-based series. And today I'm delighted to introduce a good friend and colleague, Leah Hicks. She is a program manager at the Corporation for Supportive Housing and oversees the Indiana office of that group. And as part of that, she organizes Supportive Housing Institute, and she does a lot of training and consultation around assertive community treatment and supportive housing options. She has over 30 years of experience, and I'm happy to say, I can't believe it's been this long, but I have worked with Leah for over 20, maybe even 25 years of that time. We were part of the ACT Center of Indiana, which we still are part of that, but we used to do a lot of training and consultation together as part of the National Evidence-Based Practices Project. So I'm really excited that she's here with us, and would like to turn it over to Leah now.
Great, thank you so much, Michelle. I know we're far too young. We started when we were 12 or something like that. So, so let me get my slides up here and get us going. Come on, slideshow. Great. Everybody seeing slides? Does that work, Michelle? You're seeing them? All right. Super. Well, I am so excited to be here with everyone today to be talking about 2 really important evidence-based practices near and dear, as Michelle said, assertive community treatment. I've been involved with for a very long time, and supportive housing as well. That's my job, focusing in on supportive housing, TA and things is a little more recent, but have been involved in it for a very long time. So today we are going to hone in on an introduction to both of those evidence-based practices, and then also talking about how both of those models really serve in meeting the basic needs that support recovery of the persons that we're working with. We certainly are going to do kind of a surface, scratching the surface of talking about both of these today, given our limited time, but hopefully have some references and information for you as far as diving deeper into content and information about these two important practices. So let's start by talking about Assertive Community Treatment, or ACT. There is a SAMHSA toolkit for ACT. So this slide provides that link. So when you get those slides made available to you after the webinar, you can access that toolkit. ACT has been around for quite a while. So we're looking at about 50 years at this point. And it was initially developed by Leonard Stein and Marianne Test, who both were practicing in a state hospital in Wisconsin. And they were recognizing this revolving door phenomena that existed with individuals coming into the state hospital, where they would come in with acute and chronic needs and symptoms and need all the intensive services and variety of services that were available in the hospital. So not just the meds, but the rehabilitative services and the therapy and the counseling and all of those different things. But what they also then recognized is as people improved and went back to their homes, back into their communities, we saw that this was a revolving door. So that same level and intensity of services wasn't available in their communities. And so unfortunately then people didn't have easy access to physicians, psychiatrists, therapists. Maybe transportation was a barrier, there were other barriers. And then unfortunately, over a period of time, people may then have a decompensation and experience rehospitalization. So Stein and Test said, why can't we create this notion of a hospital without walls? Why can't we create teams and programs that do provide this intensity and this multidisciplinary approach and meeting all those needs, but being able to do so outside the walls of a hospital? So that's where ACT was really born. And now we have about 50 years of research that shows that ACT as a model indeed is effective at helping people move forward in recovery and really being able to thrive. So we think about ACT as a self-contained clinical team. That's one of the foundational elements. And if you've had involvement with ACT, or even if you haven't, being able to let you know that there are these fidelity tools out there, the DACT, D-A-C-T-S, and the TMACT, T-M-A-C-T, two different fidelity tools that really measure the adherence to the ACT model, looking at the quality, the level of implementation. So I just mentioned that because we're going to be talking about some of those fidelity elements today. What makes ACT ACT, what sets ACT apart from other types of mental health or substance use services. So we're going to hone in on some of those today. Again, I do ACT 101 trainings that are 2 days long. So again, we're really just highlighting some of the areas, but would point you back to the toolkit that SAMHSA has to really, for you to be able to dive into a lot of these further. So foundationally, ACT directly provides the individualized treatment needs for individuals, those rehabilitative needs, those supportive services, and minimally refers clients to other providers. So that's one of the foundational elements that ACT, in most cases, is able to meet all those rehabilitative, mental health, substance use supportive service needs that individuals may have. So we don't broker out to other providers, even within our own agencies. And we'll talk a little bit more about how we do that. ACT is more of a long-term service, long-term program. And so what does long-term mean? Well, usually a couple of years, anywhere to many years. I know people that have been served by an ACT team 10 or 15 years, that's what their needs and what works for them. But because of the nature of individuals coming onto the team, as well as sort of that, the different areas and domains of their lives where they need assistance and meeting those basic needs, we usually see people being on an ACT team for at least a couple of years. So we're really able to provide that continuity and build those relationships. An ACT team operates from a shared caseload or a team caseload approach. And that'll become a little more evident as we talk today, to be able to meet all the different needs and provide services across many sort of domains I refer to for individuals. We need to have a highly specialized team, and those team members have different skill sets and come from that multidisciplinary approach. And so we provide a shared caseload approach. It's not my caseload or your caseload. We work together to meet those intensive and frequent needs for each individual. And therefore, it has to be highly individualized and really tailored, focusing on what each person needs. So we don't just have a one size fits all. We have the qualified staff in that team that can really hone in on prioritizing and what it is that each person needs. So that leads to that idea of being state of the art and providing those interventions that really support recovery, and that ACT is really an excellent platform for using other evidence-based practices. So I know Michelle has talked about IMR, and Andrew Rollins is going to talk about IDBT. I think Marina, or you might have that wrong, but other folks are going to talk about supported employment. So while ACT in and of itself is an evidence-based practice, it's a great platform for other evidence-based practices. So here are the staff members that make up an ACT team. So when I talk about multidisciplinary in nature and that team approach, when you see this list, you've got highly specialized individuals that can meet those different individualized needs that each person will have. Yeah, Jessica, ACT is Assertive Community Treatment. And so we've definitely, again, have a multidisciplinary team here when you look at all the different roles and backgrounds and specialties that people come from. So the fidelity tools narrow this down a little bit more. For high fidelity, some of these positions are absolutely required, and it looks at how much of different positions, FTEs and things you must have. Again, when we put this group together, you can see why they're able to practice as a self-contained team. And then looking at some of the basic elements. We talked about multidisciplinary staffing. We talked some about a team approach and what makes that so important, and how the team can work together. Integration of all services. So again, if you think about, okay, we have this team of 8, 10, 12, sometimes more staff, and an ACT team can serve anywhere from 50 to 100 clients or consumers, then yes, we've got to figure out, how do we integrate all of the work that needs to be done, but also integration from the standpoint of how do we look at symptom management and coping skills and how that interplays with someone's goal of getting back to work successfully. And so the integration of staff working together, the integration of those services to meet those needs. ACT has a low client to staff ratio. And from a fidelity standpoint, that's 10 clients for every 1 staff. We don't count the psychiatrist or the prescriber in that ratio. So if a team is going to serve 100 individuals, they're going to need to have at least 11 staff if they're including that psychiatrist. So again, these teams can be large, and you know, again, needing to have that low client to staff ratio to meet the needs of this particular population. And we'll look at some of the admission criteria here in a minute. Locus of contact in the community is also a key element of assertive community treatment. We're very focused on eliminating barriers and making sure that people have access to services. And so 75 to 80% of the face-to-face services that are provided to ACT clients are done so in the community. And by community, we mean home visits, or we mean at their jobs, or, you know, being with them at the grocery store or at their doctor's appointments, in their communities where they live, recreate, work, socialize. And again, there's not that expectation that individuals have to come into an office for to meet their needs. We want to, you know, eliminate that as a barrier, because we know there are so many barriers that keep people from coming into an office, especially with a population that has more intensive needs. Assertive outreach or assertive engagement is foundational to ACT. Lots of times individuals who are referred to assertive community treatment haven't had great experiences in the mental health system before. There are lots of barriers that exist, as I just mentioned, for making it difficult for them to access traditional mental health or substance use services. And this isn't necessarily a traditional population. We're looking to work with a population that doesn't do well in traditional services. If someone's doing well in traditional services, that's great. We're looking to serve a different population. And that population tends to be, again, people with a lot of barriers, people who maybe don't have that trust in our systems, and you know, or maybe symptom-wise or cognitive-wise, there's reasons for why they struggle to access services or engage with us. So our goal is we don't give up on individuals. We're out there assertively engaging, figuring out what it is we can do to provide those supports to make those connections. And whereas in traditional services, you know, you may miss 3 appointments and your chart gets closed, or you're put into a different type of programming. With ACT, we are working sometimes up to 6 months to creatively figure out how to engage people before we would consider, quote, closing a chart or a case. Focus on symptom management and everyday issues. And so that's what we're really honing in on, that rehabilitative approach. What are those basic needs? What are those priorities that you know, we can help people focus on that eliminate or decrease symptoms and help people, you know, get to that point where they're able to manage their everyday needs and move forward in recovery. And then ACT teams are available 24/7 in some capacity. They have their own after-hours crisis systems. And back to that idea of a self-contained team, we're really honed in on the ACT team being able to provide and meet those crisis needs. So I mentioned we'd talk about the typical admission criteria for ACT. You know, here are some of the main bullet points. What's important about all of these is ACT teams need to operationalize these. So It's not just frequent psychiatric admissions. An ACT team would identify on an ACT admission form or in their criteria what is the definition of frequent for their program or their agency. Is it 2 psychiatric admissions in the last 12 months? Or is it something less or more? Is it number of days? So those sorts of things. But again, we're looking at individuals who are kind of cycling through our systems because their needs aren't getting met otherwise. So those psychiatric inpatient admissions, frequent use of emergency rooms as opposed to seeking out psychiatric care, homeless or unstable housing. So we'll see how that will tie to our discussion about supportive housing here in a few minutes. Individuals who kind of have that treatment non-adherence profile. So folks who've not done well in that traditional, more office-based approach, and really need that assertive engagement and outreach and more of that community-based approach. Individuals who have a dual diagnosis, and in this case, we're referring to serious mental illness and substance use or abuse. Individuals who may have justice involvement or legal problems. And then also that discharge from long-term hospitalizations or state hospitalizations, institutional type settings. So again, this is, a list that again will need to be operationalized. And we know that sometimes people meet criteria in more than just one category here. But hopefully this starts to give you a sense of the group of individuals that ACT looks to serve and how this is different, again, than I keep referring to that traditional population or people that don't need a level or intensity that individuals who are having these experiences with these functional impairments may be having. So again, we want to reserve ACT for individuals who have have these outcomes or are using these systems, and again, use ACT sparingly and use it for those individuals who most definitely need it. So the primary goals, certainly it makes sense that one of the goals would be to lessen or eliminate the symptoms of mental illness that the individual is experiencing, and being able to minimize those recurrent acute episodes of the illness, decrease the chronicity that individuals are experiencing. To go along with that, we want to help satisfy those basic needs and enhance quality of life. And that seems just sort of, oh, enhance quality of life. Well, that's kind of a broad statement. But if you're experiencing the things that we were just talking about on the previous slide, in and out of systems and having a lot of functional impairments and sort of these negative consequences, if you will, tied back to symptoms and one's experience with mental health, then getting back to meeting those basic needs and really honing in on making every day a better day and moving forward in recovery. I mentioned improving functioning. So that's, really key and ties back to quality of life and basic needs. How do we help people improve their functioning in lots of different areas or domains, social, employment, but we're going to talk again, about housing here in a minute. So lots of different areas where we look at improving functioning. Increasing control is another one. So as people have these negative experiences, lots of times that control is stripped away. So how do we, as ACT providers, make sure that we're really involving clients in decision making and helping give back and build back that control that individuals have over their lives and over the treatment they're receiving. And tied to that is working with families and kind of lessening families' worries and concerns, and sometimes the responsibility that they have for providing that care, and trying to look back at, quote, some more normalcy around family relationships. All right, so that was the quick 20 minutes Act 101 to give you that overview. Oh, I got a slide advancing on its own there. But let's shift over to talking a little bit more about now supportive housing. So we have supportive housing as a general term sometimes. So, and then we have supportive housing or permanent supportive housing. Sometimes it's PSH. So we love our acronyms, right? So today I'll refer to it as supportive housing, but if you ever see PSH, that's permanent supportive housing. As a model, has some very specific elements and tenets, just like ACT does. So, you know, as I mentioned with ACT, we don't have time to get into tons of detail, but the organization that I work for, the Corporation for Supportive Housing, or CSH, if you go to the CSH website, you could be there for days. So lots and lots of different resources, data, research, lots of tutorials. There's a training center. So much out there to really expand your breadth around supportive housing and different things related to supportive housing. So one of the things I will want to talk about for a few minutes and sort of tying to and grounding around supportive housing is most of the time we see supportive housing as an evidence-based practice tied to serving households that are experiencing homelessness. Sometimes it's a person's at risk for homelessness, but in most cases, the ways people access supportive housing is through like local coordinated entry systems, through their local continuums of care, which again, we don't have time to go into tons of detail here, but a lot of HUD or a lot of supportive housing is funded through HUD dollars, through home dollars, housing trust fund dollars. There's so many different kind of different types of financing that go into, and therefore then a lot of rules and regulations around who gets served. And so that's why I tie it back to, as an evidence-based practice, supportive housing is usually tied to households experiencing homelessness. So if we look at the 2020 national data, when we look at the PIT count, as they refer to it, on a single night in America, over 580,000 people experiencing homelessness. There's lots of other data and breaking that down on this slide as well. And you'll see that there's a link there to access more data. But we're talking about, you know, over 500,000 individuals on any given night. And so, you know, the next night those numbers might still be 580,000, but they may be made up of slightly different individuals. So it's not a true number of the number of people that experience homelessness, say in a 12-month period. This just tells us on any given night. Additionally, CSH has a national supportive housing needs assessment tool. So looking at not just that point in time, one night, but also thinking about what about all the people who live in institutions, people who are in our criminal justice jails and prisons, people who are involved in child welfare system or in the foster care system. So lots of different individuals never get counted in this one night count or get counted at all because they are institutionalized or they are housed or being served in systems that aren't counting them. But were they not in these systems or in these institutions, they too likely would be homeless. So CSH really took additional data and sort of counted and looked at subsets of people in institutions and, you know, got a bigger, more complete picture. And the data really shows us that there are 1.1 million households, if you will. So we're not talking about 1.1 million people, we're talking about households, or you could say that there are 1.1 million homes needed to meet the needs of individuals experiencing homelessness or individuals that could leave institutions and benefit from supportive housing. So just to kind of make the point that we have so many people, you know, across our country that are in need of supportive housing. Also want to speak a little bit to disparities that exist in supportive housing. And if we look at racial disparity data across all 50 states, you'll see on this slide that regardless of what state you're in, there is a disparity, racial disparity, when we look at the number of individuals who are experiencing homelessness, who are people of color. The slide looks specifically Black to white homelessness. So if we look at the national percentages of people who are people of color, or people who are Black, compared to how many people experience homelessness who are Black, we see these stark disparities, you know, anywhere from 1.7 all the way up to 10 times that disparity. So, you know, I really want to center the discussion or get us, you know, thinking about the fact that when we're talking about people experiencing homelessness, we have a huge racial disparity in our country, and in whatever decisions we make nationally, locally, regionally, when it comes to how we provide supportive housing, who lives in supportive housing, who has access, we really need to be thinking about these racial disparities. This is hard to read, but CSH has what we refer to as the Racial Disparities and Disproportionality Index, the RDDI. And if you go onto the website that's provided here, you'll get to the RDDI, and it allows you to drill down on any of the colored blocks that you see here that are different race and ethnicities. You can drill down and look at real data. You can look at state level data, you can look at regional or local data, and get a lot more specific data, if you will, around these disparities. So again, urge you to look into that as a resource or tool. All right, so what is supportive housing? I'd like for everybody to think about that for a minute and throw a few words in the chat. What do you think supportive housing is? What's the definition? Throw some ideas or words out there. I see allocating resources, wraparound housing service, okay. Helping obtain and maintain housing, relation, like sober living, like transitional living, assistance with housing needs. Yeah, Caitlin, I'm glad you brought that up. Supportive housing is different than transitional housing or sober living. supportive housing focuses on permanency, and really honing in on permanent supportive housing, and that there's a place for sober living, there's a place for transitional living, kind of in that continuum. But supportive housing really looks at getting people into housing without conditions, without barriers, and being able to help them obtain and maintain. And we'll discuss that a little more, but I did want to address that because I think that's a really important one. These are great, everybody. Helping encourage safe grounding experiences. Let me go back up a little bit. Cost-effective way to assist people with stability, meeting housing needs, setting them up to live on their own. Housing first with wraparound services to support individuals. Yeah, Emily, we're going to talk briefly about housing first because the two definitely, supportive housing and housing first, really have this parallel approach and very much the same philosophy and key elements. Great. Thanks everybody for sharing these. Definitely key. You guys are hitting some of the main key elements of supportive housing. And just to give us the concise definition, and then we'll build from there. Supportive housing combines affordable housing with services that help people who face the most complex challenges to live with stability, autonomy, and dignity. So we're going to pull out of here these pieces of affordability and combined with services, which are just very, very key. So supportive housing, if it just has an affordability component, the housing does, then it's not supportive housing, it's affordable housing, which is horribly important. We know that there's such a lack of affordable housing across the nation. I think I saw a number, 60-some% of just individuals, citizens in our country right now could use some sort of rental assistance to help with affordability. So this is, an issue that reaches far beyond the population we're talking about today. But supportive housing as an evidence-based practice must have the affordability component, and it also must have a services component. And these are voluntary services, but their services are available. They're available on site. They're available from a referral standpoint. It depends a lot about whether it's a site-based program or the units are scattered site. But this is where we start to see where ACT and supportive housing kind of have this intersection, or can have this intersection. Because ACT teams are a great way to provide services to individuals who are living in supportive housing. So we'll dive in a little bit more here, but those are two key components. There are 6 main components. We're going to talk a little bit about each one. First one is engaging households with multiple barriers. So as we talked about with ACT, that ACT admission criteria, we saw individuals that have some of the similar barriers that we're seeing here, but we're really honing in with supportive housing in working with people who without services would not be able to access and maintain housing, and without housing are unable to effectively engage in services. So you've got, both of those things going on. And when we look at individuals, again, I mentioned we have so many people that have very low incomes and need the affordability component. But for supportive housing, when we look at individuals on this list here on the slide, these are people who disproportionately use shelters, use emergency health care, maybe to meet just basic healthcare needs, but they're utilizing the emergency room. other public mental health services, or other ways in which they're cycling through various systems and public institutions. And so, you know, thinking about, again, from maybe an admission criteria standpoint, this is often who we see needing supportive housing and having those barriers. Housing is affordable, so I talked about that. No more than 30% of a household's income goes towards rent and utilities. Again, we know that that's not necessarily the norm, even across the general population, but with supportive housing, with rental subsidies, that's an expectation. And so we, again, could talk all day about different types of rental subsidies. What do we mean by that? Some examples might be project-based vouchers, Section 8 vouchers. There are other types of vouchers that local housing authorities have access to. So sometimes those are reserved specifically for people experiencing homelessness, or they're a certain number are reserved specifically for a supportive housing, a building or development. But we know people get those vouchers and carry those vouchers themselves, right? And then say, hey, I have a Section 8 voucher, I want to live here. So that scattered site piece too. There's also rental assistance through what we call the continuum of care. And that's funneled all through HUD and has a very complicated competitive process. Competitive at a local agency, not from tenant to tenant or client to client. So there's a lot of stuff out there. There's not enough rental subsidy for sure, and how they're administered and funded is highly complex. I would be lying if I wasn't saying I'm still learning about some of the intricacies of that. But that affordability factor is key in supportive housing. Providing tenants with a lease is really important. So we want barrier-free applications. And when we talk about barrier-free, we're really talking about in supportive housing, we don't have those traditional criminal history barriers that keep people out, you know, for even minor criminal offenses. We don't have barriers related to keeping people out because of past evictions, or keeping people out because of bankruptcies, or you know, a poor credit report. So really looking at screening people in rather than screening people out. And that's the big one. When we say you're developing projects and properties and using grants to house people experiencing homelessness that have all these other barriers out there, why would you be screening them out? The point is to screen in and work with this population to really provide those opportunities that they haven't had. And the lease is a legal document. And tenancy supports is something we'll talk about here in our last few minutes. Tenancy support services and how those are really meeting basic needs. And that the lease protects tenants and landlords, but it helps us get to identifying, you know, what are some of the things in this lease that might be problematic for a person. Maybe they've had issues with getting along with their neighbors, or maybe they have guests that cause issues on the property. You know, if we know these things, we can provide services and skills around these areas that help them not violate their lease. Those lease violations lead to eviction. So really honing in on the lease in a different way. You just signed a 20-page document, but let's really look at what are the things that could get you in trouble. And thinking about that, those are the services we ought to be providing when we think about basic needs and prioritizing. You know, let's provide services that are connected to that stability over time. Flexible voluntary services. So, you know, we've talked about this and how important it is. Services are voluntary, but they're available. And so people are not denied housing in supportive housing because they do not want to participate in services, or they don't want to provide or participate in particular types of services. That's where assertive engagement is so key. So we provide a wide range of different services that focus on the needs that people have. Those tenancy support services that I just talked about, avoiding those lease violations, what are the unique needs that people have, and assertively engaging people, building those relationships. So maybe they will get into services. But again, we're not telling people to move into this housing, you must engage in these services. That's not supportive housing. Coordinating with partners. So while we have services available and on site, making sure we can connect with behavioral health care, physical health care, employment, education, whatever it is the households need, that we can make those strong linkages and connections with key partners. And then that wider connection with the community, making sure that the units are in safe neighborhoods that are also close to all of these important things. We don't want to create more barriers. Hey, this is a great, apartment complex, but it's 5 miles away from everything, and there's no bus or public transportation, or so making sure that those needs and amenities are accessible to individuals, and that people can access and participate in their community where they're living. Okay, someone mentioned housing first, and again, housing first and supportive housing really are parallel and run closely together. The goal of housing first is housing people as quickly as possible. We want to reduce trauma, that people experience by not being housed, and then provide that voluntary services that meet the needs that people have. These are core housing first principles that really align with much of what I've said today about supportive housing. The link here will take you to a series of YouTube videos that were put together by Pathways to Housing, originally out of New York City. Sam Barris, the father of Housing First. These are really great videos. I think there's 5 or 6 of them that really do a super job of further exploring housing first and supportive housing. Each of them, maybe 6 or 7 minutes long. Okay, that intersection of ACT and supportive housing. I know I've been talking a lot. A few more minutes, and then we're going to do questions and answers and get into a little bit of discussion. But talking about basic needs, I've been throwing this in throughout in threads of how ACT really focuses on meeting those basic needs, but so does supportive housing, especially from that standpoint of those tenancy support services, making sure that we're helping people maintain their housing. So first of all, thinking about housing as a basic need, and not just as a basic need, but as a human right. I have multiple things listed here. Housing is healthcare. It's a social determinant of health. If we don't have that basic need of meeting people's housing needs, then it's really difficult to move forward with recovery and other aspects of recovery, and meeting other basic needs, and moving forward and being able to thrive. We know affordable housing is scarce. We know supportive housing is scarce and often difficult to navigate. So I just want to acknowledge that we have a horribly complex system that's difficult for anyone to navigate and access. So what are some of the basic needs, supports, or skills that support housing stability? So go ahead and throw some of those in the chat. What are the things that you think of when you think of meeting basic needs, or what are some of those basic skills that support housing stability? And if you'll throw those in the chat, and we can kind of have a robust list there that we can come back to as we talk about our Q&A. I will go ahead on to the next slide, but definitely put those things in there. Yeah, budgeting, financial management, natural support, transportation, food nearby. Super. So one of the core areas of service provision on ACT is housing. So I kind of want to tie this back, right? We talked about having a housing specialist on the team, or at least having a generalist, maybe case manager, who has a background in housing, but someone on the team that responsibility is to really hone in on working with people around housing. And we also know that one of the common admission criteria for ACT is homelessness or at risk of homelessness. Yeah, this is a great list, everybody. Yeah, Elizabeth, you're a housing specialist. Woo. So, some of those common housing needs and services that an ACT team might provide is kind of that overarching outcome goal, right, of obtaining and maintaining that stable housing. So finding the housing, and is it affordable, negotiating those leases and paying rent, and working with landlords around, issues that may come up around a lease or a lease violation, purchasing and repairing household items. So, making sure that, okay, somebody's got a unit available, but we don't want them moving into an empty unit, or, when they need to replace different things, and when is that a landlord responsibility versus a tenant. Those relationships with landlords, and building relationships to find units, but also maintaining those relationships, working with the neighbors in the community. And then you see those tenancy support skills again. And those are endless. So helping people with their daily living skills, helping them, build those skills to get along with their neighbors, and maintaining the unit, the upkeep of the unit, what that looks like. So, those are just a few of the tenancy support skills. But you can see now where we kind of have this intersection of supportive housing. ACT might be providing services in supportive housing, or there are times when we have ACT teams that are directly supporting folks in a particular building, or supportive housing building. But supportive housing, again, should be providing on-site services. I work with a lot, we do an institute each year. We have teams come together, and the goal is to build supportive housing properties. Sometimes they're 100% supportive housing, sometimes integrated. But part of that is there's a service provider on that team, and they're committing to having on-site services staff. Sometimes those are ACT teams that are making that commitment, but they may not be. They might be staff from a community mental health center, a federally qualified health center, other community agencies, or sometimes we have developers that hire their own services staff. And so you kind of see the list of case managers, skills specialists, people with lived experience, or peer specialists, just to name a few. And then how do we also work on those community-based services? And so, sometimes there are office-based services that people have to go to. But really wanting to again make that connection that services in supportive housing, that ACT can be one of the main service providers out there in serving people in supportive housing, whether it's a building or it might be people scattered throughout the community receiving rental assistance through HUD grants. So there's lots of different things. So I know I've blown through this, but I really wanted to take some time for questions and get a little more interactive in the few minutes that we have.
Awesome. Thanks so much, Leah. Thank you, everyone. We've now reached the Q&A portion of today's webinar. So please feel free to submit your questions by typing them into the Q&A feature. We do already have one question in the Q&A feature, and that is, what can citizens do to keep the prices of housing low?
Yeah, gosh, I would, the first things that come to mind are like, be involved as much as possible in your local government, regional government, like wherever you can, you can have that impact. Really be aware of what's happening in legislation. Even locally or at the state level, there are so many things that are out there as far as bills and legislation that you can go to the public hearings about, or be a participant in, and things just kind of get swept under the rug sometimes. And so being active in that role, in that way, being informed, being an advocate. I think using our voices is so important, and speaking, to what we're seeing in our communities, because we know it's affecting so many people. We're talking about a subset of individuals today, but knowing that housing affordability is becoming an increasingly problematic area for folks.
All right, thanks so much. Our next question in the Q&A feature is, what is the role of a clinical psychologist in supportive housing?
I think, I can think of several different things. And again, depends on, as a psychologist, where you practice. If you're practicing in private practice versus maybe in a community mental health center setting. But oftentimes, we need psychologists to be able to provide proof and documentation of diagnoses and disability and those sorts of things to help people access supportive housing. One of the things we didn't talk about a lot today was in supportive housing. A lot of times the requirements of people who are experiencing homelessness, they also have to have a disability to be eligible for some of the HUD housing and those sorts of things. Being able to, provide diagnoses, provide documentation of such. I think also differential diagnoses. We've got people who come with so much, different diagnoses over time, is sort of parsing some of that out and figuring out what's really going on for individuals. I also think that you asked specifically to supportive housing, but on ACT, we've had teams that have psychologists that are a part of the ACT team and can also be really supportive in providing those clinical interventions and helping people, really hone in on what it is, what their goals are, and how to get there. I think clinical psychologists also are really helpful in supporting colleagues and helping them better understand, who they're working with and what those clinical profiles look like, and just providing that cross-training and learning.
Thanks so much. We have time for one more question, and that's going to be, in keeping with the fidelity model, how do you handle staffing shortages?
Oh goodness, Jennifer, that's tough, isn't it? I think that when we look at fidelity, certainly the tools say, okay, you must have this many of this type of people to score a certain score, and those sorts of things. And so while it may impact an actual score on an item or an overall fidelity score, I think being able to have that conversation and that understanding of why is that, and getting to exactly what you're saying, like, we have this staffing shortage, and this is why, this is what we've been doing to work on filling it. This is how we're kind of maybe filling in those gaps to still meet the needs of individuals. And so I always thought about it, you know, when I was more intimately involved in doing fidelity, is working more with the team on identifying, well, you know, not so much the score, but how is this impacting your team and the clients, and how do we, you know, figure out how to manage that? Again, like filling in those gaps, you know, recognizing that right now we're in unprecedented times with staffing shortages across the board. And rather than being coming from a penalty standpoint, instead really working closely from more of a technical assistance standpoint to how can we help, how can we support you, and still serving those needs.
All right. Thank you so much, Leah, for your presentation and for answering our questions. That is all.
Thanks, everybody.
Yes, thanks so much. That's all the time that we have allotted for question and answers and for the presentation today. So we're going to go ahead to evaluation. I've put the evaluation link in the chat for everyone, but we want to thank you all for your participation in today's event, let you know that we value your feedback, and we hope that you will complete this brief SAMHSA required survey by visiting the link either presented on your screen or in the chat. Afterwards, you'll be automatically redirected to additional questions from our center regarding the impact of this event on your knowledge and skills. And again, we would like to really thank Leah for being with us today and giving this awesome presentation and for answering our questions. We really appreciate it. And we hope that you all will join us in 2 weeks for the 4th session in our Keeping It Practical series. So thank you, everyone. Thank you, Leah, again. And that is going to conclude today's webinar. Thanks, everyone.